Good morning. It's great to see you all here, despite the rain. And I hope you had a wonderful dinner last night and even some dancing. I think the conference has been excellent so far, and I hope that we can further inspire you with this plenary session on tackling health inequalities, and particularly to bridging to migrant communities. We know that our societies are changing. We've heard that several times during this conference. And I think the main question is, how do we as public health researchers, public health practitioners and professionals, how do we respond to these changes? We see increasing urbanization, rising inequalities, we see increasing health inequalities and discrimination, and what can we do about it? Fake news and fake facts are really used to undermine trust and divide people and communities. This leads to mistrust in society, social exclusion, and clear consequences to health and health equity. How can we better address the needs of migrant communities and those that are facing disadvantages? I have 5 fantastic panelists here who will be able to give their perspectives on this issue, and also from their European policy overview and from the local level. But before we move to the first speaker, I would like to ask you to join me in responding to some of the statements. So I would like you to go to www.menti.com and use the code 483294, because you would like to fact check with you some of the statements that have been researched and investigated in the Lancet Commission on Migration and Health. The first question is, fertility rates among migrants are higher than among host populations. We wait a little bit. Okay, let's go to the next question. It's a bit of an impression to see what you think. Migrants are damaging economies. The next question. Migrants are a burden on health services. Okay, I think we get an impression. You are a very informed audience, but these are 3 of the main beliefs that people have about migrants. And it is very important to see how we can provide factual information to everyone. And I'm delighted to now give the floor to Bernadette Kumar. She's co-chair of the UCL Lancet Migration Commission and also director of the Norwegian Unit for Minority Health Research. And what can we do to correct this myth?
Good morning, everybody, and it's very good to see so many people here on a Saturday rainy morning. I think the questions that have been raised, Caroline, are very good examples of what we call migrant myths. And I'm pleased to say that the Lancet Commission for Migration and Health was very instrumental in trying to bust some of these myths, because these myths have become a part of the political rhetoric. What is extremely unfortunate is not only are they part of a political rhetoric, but the fact that we have the data, the fact that we have the information that counters these myths is not acknowledged. So it's extremely disappointing that not only is it not acknowledged, but it's not even used. from the European perspective, I'm also pleased to say, along with the Lancet Commission, which was global and which really provided the fundamentals for this information, we also have the WHO health report that was launched this year in 2019. And that gives you data from Europe. So we can't say anymore that we don't have the data, we don't know, we actually do know. So oh, I'm not yet finished with that slide. So I think that if we take some of these very common myths, you hear that very often, that migrants are overwhelming high-income countries, migrants have very high fertility rates, migrants are damaging economies, migrants are a burden on the health system. The question is this true, false, or somewhere in between? And actually, for a lot of these myths, they're not simply true. For example, we know that the whole issue of fertility is a very complex issue. It's not something that is static either, it's changing. And what people forget is that there are these images of migrants having 30 children, which is not true in any case. But a lot of people will say, I know some family who has 30 children. And it might be true. They know that there's one family who has 30 children, which is also not possible. But anyway, those are the kind of things that you hear all the time. And this is not true, because there are birth and death is affected also by inward and outward migration. And there was this large longitudinal scale study, which is from 6 countries, that was done in Europe. And it showed that migrants actually have lower first birth rates compared to non-migrants, except for Turkish women. And we also see that birth rates among migrants were barely at the level of the population. In fact, we found that it was falling. So we have the data, and I've got the book with me, and I would recommend that everybody looks at it. So if anybody doubts you, whether it's politicians or others, you can go back and refer to it and said, we have that. So that's an example. The other thing that we hear a lot is about migrants damaging economies, and they're really a burden. But this is not true, because what people do forget is that while one portion of the migrant population might be refugees and they might be in need, a large majority of migrants are actually labor migrants. And labor migrants do contribute to economies, and we find that this evidence is often dissipated in the information that is shared. And we also see that in a lot of advanced economies, each increase of 1% in the migrants in the adult population actually increases the gross domestic product per person by up to 2%. And we also know that there's a huge amount of remittance that is sent by labor migrants. So the fact that they're damaging economies is actually not true either. Something which is closer to home, whether migrants are a burden on health services. And we hear that, and I was pleased to see that in the mentor meter. I think, at least for this audience, which works with health, that you got it right. They're not a burden on the health services. In fact, migrants often really make up a large percentage of the workforce. And I mean, in the UK, you have almost 37% of doctors that are of migrant backgrounds. So you find that migrants are part of the health workforce. But also those who, it's a very natural thing that a lot of migrants actually do not know how the health system works. And because they don't know how the health system works, they don't access services. And what we do find, and there's enough data to show us that, is that they actually access healthcare services much later. So they come in with diagnosis, a much later stage of the diagnosis compared to the rest of the population. So it is not as if the migrants are overwhelming the health services either. So I think it's very important for us, as the scientific community, as the health community, to really not only acknowledge that these are myths that are very prevalent and being used as part of the populist rhetoric, but actually to go back to the data and information that we have. And migrant health research has really come very far. And we also see that this is of particular relevance in urban settings, because in urban settings you find that often migrants and the host population only meet each other through the media. And I'm not going to sort of blacklist the media here, but because they meet each other only through the media, a lot of this information is not really available, and it leads to a lot of tensions, and it leads to something which I think is very much an issue of concern. And those are issues related to discrimination, to xenophobia, and to migrant hate, which is not good for health either, because we find that over a period of time, that really has an impact on the health of migrants, but also the health of the host population. So I think that, you have to give me an indication I can keep talking, Karen. So, if I
1 minute.
1 minute. So I think that what I'd like to say is that and the European report that we have, that WHO published this year, also is very much in concordance with the Lancet Commission, and that was very, very important for us, that we're not all saying different things. And actually, the European report gives you data from Europe. And it's very important then to look at this data, look at mortality rates. For example, we find that migrants have lower mortality rates. So I think that what's really important is not that just the fact that this data exists. Of course, I'm not going to say we have all the data. As a researcher, as a scientist, I would like very much to have more data. We're missing some data, but we have enough data to counter these myths. And I think it's really a fundamental issue for all of us to be doing that. So I would really encourage people to use the data that exists, and it's also part of our mandate to be disseminating this data,
Yes.
to be, in a way, I don't like the word educating, but say dialoguing with policymakers, with politicians, both at the local level and at national levels, and say, this is the data we have, and correct these myths.
Yes.
And often I think it requires a bit of courage, but once you stand up and say this is a myth, I think people will say, okay, show me the evidence, and then we have the evidence to show them.
Thank you. Thanks a lot for your call for more evidence. What is it we need to tell more stories? We need to tell new stories based on this data, because we have to tackle very much also this discrimination, and this discrimination is one of the underlying causes to a lot of problems and health problems, and you can see it almost as a social determinant on its own, no? So telling new stories based on data is extremely important. Thank you, Bernadette, for that. And let's now move on to Santino Severoni. You are Acting Director at WHO Europe and Special Advisor on Migrants and Health. So what is now being done by WHO? And how is WHO guidance taken further in by member states?
Yeah. If you can have my slides?
Yes.
Yeah. It's not another false myth to be diffused, but certainly I want to take this opportunity to give an updating of the situation. Only a few years ago, we were complaining, the public health community was complaining of not engagement of health sector and public health community into this topic. Too often we have seen the health issue being tackled as a complication, as a side effect of the migratory process rather than a founding principle for people's well-being. Then we really injected major efforts to advance and to promote WHO principles and approach in all the most important policy framework at the global and regional level. We started with the Regional Office for Europe in 2016 with a strategy and action plan. It was the first ever in WHO. It was actually adopted with a full consensus of countries, which today they also manifest a quite conservative feeling about migration movements. But still, our findings are in the implementation of the action plan. Even those countries are implementing and sticking to the commitment taken 2 years ago in 2016. Today, the analysis of the situation is that probably 50% of our member states in the WHO region are engaging into mainstreaming at the national and local level policies related to migration, developing sensitive services to migration, engaging into capacity building, setting up migration health unit at the Ministry of Health, and the most committed. Globally, we also felt important to hurry up to fill a gap. globally, there was mentioning of migration. There was a resolution a few years ago related to the health system sensitiveness, but really there was not a very strong position, and we advocated and we moved in that direction. We had recently a resolution, a global resolution, World Health System Resolution 7015, which really pinpoint the principle of migration health work for WHO. Then the global action plan followed last year, and then more recently, one more click, please. One more click, please. One more click, please. No, back, sorry, it doesn't get it, yeah. Back, please.
Back?
Yeah.
Yes.
And then recently, the global program of work. Basically, we have included migration health work at all target billions of the global program of work to ensure that all regions, all WHO capacity will invest into the work of migrant health and refugees health. At the global level, also two important things happened, actually more than two, three important things happened. The two global compacts were adopted last year. Was a very difficult process, very politicized, very polarizing, very confronting in many cases. We observed also political crisis because of the adoption of the Global Compact. However, I like to look in a provocative but also in a positive way what happened. Today, most of the world member states, WHO member states, agree to have a compact on migration, to renew the commitment in protecting refugees with a compact on refugees. And the important element there is that through a very strong, complex advocacy process, we managed through champion countries to have a very clear reference to WHO principle, framework, and global action plan in the two compacts. Last but not least, the SDG. The SDG inherited the unfinished business of MDG, but surprisingly, not much was on migration in the MDG, while now is quite strong addressing the SDG. The SDG on health commit on universal health coverage, and this year happened something extremely important where political commitment towards the universal health coverage was reaffirmed with a political declaration launched in New York in September, where again migration is spelled out in the Article 71 as a main commitment to all our member states. Next one, please, Caroline. To conclude, in all those policy frameworks, there are clear reference to national and subnational policies, actions, and collaborations. In reality, we feel that we need to pay particular attention to the local level, to the localization, because for many reasons, but mostly the integration, which is an important step for well-being also of migrants and refugees, it's basically happening mostly at the local level. Yes, the legal framework is national, but then who really solve the issue of housing, education, access to social health services? It's the local community. So we really engage into addressing our work to those local communities in collaboration with other UN agencies and OECD. And using the major fora and major platform available, like the Mayor Forum, the local government and communities, partnership with civil societies, really networking with academia, with the Lancet Commission and the most important university already involved into studying the migration and refugees health phenomenon. But more important, we establish a network of academic institutions as a WHO collaborating center, which are really an expansion of our work. Last but not least is the engagement with the Healthy City Network. WHO launched a few years ago, actually more than a decade ago, Healthy City Network. And with the mayor of this network, this is a very powerful, very political network because it's gathering about 800 mayors from all over the world. So it's a Euro initiative, but actually has an impact at the global level because what we are working and engaging with the mayors goes all over the world. Well, there we realized that evidence, data collection, production in order to have an evidence-informed approach was key. Capacity building, again, key. and knowledge sharing. So nothing new what we are doing at the national level, but we had to revisit, and we are working together with the local community to adapt to the local level. Thank you.
Okay, very good. Let's. We will see a new leadership soon at WHO Europe. We have heard Hans Kluge on Thursday at the conference, and you are the special advisor on health and migration. So what would you advise him to take further as key priority for the next years?
I feel quite lucky because in this regard, I don't think I need to give big advices to Hans. Hans have been on the forefront in the last 10 years in shaping up the health system and primary health care in this region. And is also a colleague, passionate and compassionate in his work. So every time that we've been engaging and discussing migration health, I always found very strong support and understanding. So I'm expecting the new period under the leadership of Hans to progress in this area and to expand. Practically, we're having important assist, like I mentioned now, like the universal coverage work now. So I'm really hoping and confident and positive for the future.
And the WHO has a strong advocacy role to play in order to make sure that governments are acting on this and that funding are going to tackle migration and health. And how do you see that role? And also, Bernadette, in changing the public perception, as you said, we said talking about using the facts, but it's also about making the human rights argument. How can we move further to tell these new stories and to advocate better? So what do you think should happen? First Bernadette, and then for you, Bernadette.
I think time is for action. We have enough knowledge. It will always be need for more knowledge, but we have enough action. We have enough knowledge to act. And in the European region, we're very pleased to have a joint action for reducing social inequalities. And this particular joint action is based on a lot of work that has been done over the last 20 years. And a lot of this comes from the WHO strategies. And we know what we should be doing. But the thing is, we have to get on and do it. So this joint action is really a time for different member states to come together, different countries, and say, okay, what can we collectively do? And it's only by doing that we can actually change the attitude and we can change the perceptions, because then you have something concrete that countries, that municipalities, that local communities, urban settings can actually see functioning. And unless they can see that, it's, as you say, the proof of the pudding is in the eating. And unless you have that evidence on the ground from examples like Jahi, as we call it, and it's still a work in progress, and there's a lot of initiatives that are happening. So I think we need these initiatives at local level, at municipality level, at national level, so that people can see that it works, it functions.
Yes.
Well, the advocacy role have been basically the main part of our work in the past years up to now, and will be also in the future. What we faced was clearly a situation where we felt a bit offside, unprepared in the health sector. When the situation became viral like it is now and very politicized, we realized that we were having or not engagement for lack of proper understanding, or disengagement for political fear of certain Ministry of Health and health sector. So it was really a huge effort, because we started ground zero, and we realized that in one hand we're supposed to advocate, but evidence was needed. But then we're supposed to also protect universal principle, right to health, so to make sure that in this case there was no compromising or not sufficiently value the principle that guiding WHO work worldwide. So the element advocacy basically has been producing what you have seen, what I just showed now. Really, we managed to inject our principle, our achievement, our commitment into the most important policy framework, but still we need to be boots on the ground with member states to make sure that things are happening on the ground.
Exactly. Okay, let's now move to the two member states, to UK and to Germany, to see what's happening on the ground. As Lou, you are Hiam, you are GP and also a honorary research fellow at the London School of Hygiene and Tropical Medicine. And Maryam Gardisi, you are Deputy Director of Ipso, international psychosocial organization in Germany. But Lou, starting with you, so how now would you describe the situation in the UK regarding health inequalities and migration and health?
Thank you. And I think so as Caroline said, I'm a GP in the NHS and I also work in the Doctors of the World UK clinic. And I think to understand what we're seeing, we need to understand the context of what has been happening in the UK. And we've seen some unprecedented changes with decades of improvements in health reversing. Health outcomes are worsening, health inequalities are widening, we've had reduced social cohesion, and in fact, increasingly restricted access to healthcare. And as health professionals, I think we need to be informed not only of the policy, but what's actually happening on the ground in order to take an active role in challenging what is happening. So first of all, just to look at health outcomes, this is the first time in over a century that infant mortality rate has increased for 3 years in a row in the UK. This is shocking. And if you look at this graph, you can see that it's disproportionately affecting the poorest areas of the country, with more affluent areas left unaffected. Life expectancy has stalled, but there are inequalities here as well. For example, women born in the poorest areas of England and Wales have actually seen their life expectancy go down. As you can see on the right here, deaths of despair are rising in the UK. This was a phenomenon originally described in the USA, deaths due to drug and alcohol overdose, to suicide, to alcoholic liver disease, and that's contributed to a rise in all-cause mortality. Homelessness is the highest it's ever been on record, and the deaths were the highest they've ever been last year as well for people who are homeless. And 1 in 3 of those deaths was down to a cause that was amenable to timely preventative health care. They were preventable deaths, but the barriers that are increasingly in place for people stop people getting to their health care. Go to the next slide, thank you. So why is all of this happening? Well, the infant mortality rate research looked at the impact of child poverty, and they found that 1/3 of the increase in infant mortality is down to poverty. And this is in a large part due to cuts in benefits and tax credits to households with children. In fact, a lot of the aspects of the worsening health that we've seen have been linked to austerity. And since 2010, the funding for the NHS has failed to keep pace with demand. And as you can see, it's fallen considerably behind previous levels, including previous Conservative governments, and certainly below the average of the last 60 years. Those of us working in the NHS see the impact of this every single day. People are coming to us asking for food bank vouchers, services in the community which were a lifeline, like Meals on Wheels, providing food to elderly patients, Sure Start centres providing support for families, have gone. And GPs and other healthcare professionals are left handling all this complexity on their own. So despite all of this evidence to the contrary, migrants have been widely scapegoating for what is happening. Political discourse in the UK has undermined social cohesion, and one manifestation of this has been how politicians, the media, and also now policy has been implemented. Back in 2011, our future Prime Minister, but then Home Secretary, Theresa May, described wanting to implement a very hostile environment for illegal immigrants. This sort of rhetoric hadn't been used in the UK before and really set the tone for what we've seen since. And one area that has been particularly impacted is healthcare. Sorry, the next slide, thank you. And the resulting charging regulations from this mean that for some people seeking NHS secondary care, so anybody that can't prove entitlement, so an undocumented migrant, somebody who is homeless, they would have to pay the full cost of their care upfront, and that's at 150% of the NHS tariff, not even at cost level, or be refused their care. Even for maternity care, which must never be withheld, a bill is issued straight away, and in that bill is a threat of referral to the Home Office if it is left unpaid at 3 months of £500. And bearing in mind a normal delivery costs £7,000. So with this in place, we in the Doctors of the World Clinic see the negative consequences of these restrictive measures every day. Doctors of the World have run a clinic for over 10 years in London, and last year we saw over 2,000 patients, about half of whom were undocumented migrants, but also people who are homeless, asylum seekers, sex workers, and anyone struggling to access mainstream services. The average time our service users have been in the UK is 6 years. This is not health tourism and echoes what Bernadette said. People are presenting late and not going to access healthcare. 80% are living in poverty. A bill of £7,000 is completely unaffordable. And 90% weren't registered with a GP when they came to us. They'd had no healthcare at all. And although NHS England guidance is very clear that for primary care, anybody in the UK, anybody in England, can access a GP free of charge, this isn't what's happening on the ground. The policy isn't happening in practice. Our research shows that almost 1 in 5 attempts at registration from our clinic, so that's when an English-speaking charity goes and tries to register a patient, they're wrongly refused. And the most common reason for that is lack of ID and lack of address. Lots of other barriers exist, like asking for a visa, the fear of accessing healthcare, not knowing how to negotiate the system, and all these barriers disproportionately affect vulnerable groups and are widening inequalities further. I'd like to just tell you about a patient we saw in our clinic, a 37-year-old woman called Josephine from Uganda. She'd been persecuted for her sexuality. She was forced into a marriage with an abusive man who repeatedly raped her. She escaped to the UK and she was 27 weeks pregnant when she arrived. She tried to register with a GP 3 times and 3 times she was turned away, wrongly. She came to the Doctors of the World Clinic. We were able to get her registered with a GP, but she was 35 weeks pregnant before she had her first antenatal care appointment, bearing in mind that the English guidance is by 10 weeks that should happen. When she got to her antenatal care appointment, she was immediately presented with a bill and the threat of referral to the Home Office if she couldn't pay this bill. You can see very quickly how the barriers mount up here. She's refused registration with a GP, a bill she can't pay, the fear of the link between the Home Office and healthcare, and this all has catastrophic consequences. But it's not just the UK that this is happening in. The Médecins du Monde Falling Through the Cracks Observatory report showed us that there are over 43,000 people across Europe excluded from mainstream healthcare and having to seek healthcare through a charity, with over half of people without any healthcare coverage and 89% living in poverty. We know the solutions to this. As Bernadette highlighted, we know what needs to be done. We know the importance of well-funded health and social care, of access to healthcare, and of policies that reduce inequalities. But a toxic rhetoric is dominating, and we are regressing away from equity. We are regressing away from universal health coverage. And as a public health community and as healthcare professionals, we need to make sure we're informed of what's actually happening, not just the big policies that we're told about. We need to urgently speak out. We need to keep challenging the false discourse. And we need to stand together to halt this regression. Thank you.
Thanks a lot, Lou, for your call for truly universal services and for taking away these restrictive barriers and for really addressing the underlying problems we all see related to stigma, to discrimination, and toxic rhetoric, as you are saying, which is so important nowadays. So let's now look at the mental health needs of migrants. And I'm delighted to introduce to you again Maryam Gardisi. But let's first go to a video, no? And after that you can further explain. So can we see the video, please?
There was this young lady from Somalia. She has a 1-year-old baby, and the husband has left her. And to add to the sorrow, she was pregnant.
He has headache all the time. He couldn't sleep. He started to be aggressive with his children.
She had nightmares, and she was in a really bad, depressed mood.
He was really feeling this anger inside him, and he was like really closed. He was so much afraid from the German society.
I knocked at the door and I found this young man crying there, heavy crying, and the only thing I could do is to sit there and waited.
Yeah, what you see here are our psychosocial counselors in Berlin. They describe cases in refugee shelters in Berlin and our care center also. And during the video, you see the change of attitude and perspective taking by the clients. But if you're very sad that you cannot see the rest, you can find it on YouTube. Well, after many years of experience in crisis regions and areas, Ipso has developed a specific psychosocial counseling approach, the value-based counseling, VBC. VBC is successfully established and validated in Afghanistan and project-wise also in many other regions. But after we could foresee in 2015 that we would not be able to cover the refugees' need for mental health, we brought VBC from Afghanistan to Germany. And since 2016, we are recruiting migrants and refugees with a specific background and the conditions to become a psychosocial counselor. We train them in a one-year training, consists of 3 months theory and 9 months practical work, like training on the job with weekly individual and group supervisions. So far, we have trained 140 migrants and refugees as psychosocial counselors from 17 nations. We are having currently 2 groups also right now, starting one group started yesterday. And what is interesting to say here, this group that has started yesterday are 11 migrants and refugees who have studied psychology in their home countries and are jobless. So with the training, they can learn an approach, they can practice communication skills, and meanwhile they can also try to get their certificates accepted. Here in the pyramid you can see all services that we provide in MHPSS. You have always in these pyramids in the lower levels all let's say community-based services like life skill groups, awareness raising, and so on. What I want to mention, one program is extremely successful in Afghanistan and in Berlin. We call them the Young Community Guides. You see them on the picture on the right side. These are young people we recruited mainly from mosques and trained them in a 3 months training as a community guide. Now after having this knowledge and the awareness that they could contribute and have a good impact on their own communities, they started their own small social projects for their own community, for their own families. And in all other mental MHPSS pyramids, you see that in cases of psychological problems expressed by symptoms like depression, anxiety, PTSD, they have a directly referral to the upper medical doctors or psychiatrists or psychologists. But in our case, in this pyramid, you see the value-based counseling in between, the face-to-face counseling we offer to the people and then refer them. And here we saw a 70% improvement of their symptoms. So what is interesting to mention is that our counseling reduced the load in the healthcare system, and those who really need the services, they get referred, and in the meantime we have an impact on or a good preventional work. We avoid chronification of their symptoms and also prevention of suicide and drug taking and many other diseases. And our counselors do not only help people in Germany, they are also able through our a video-based website or online counseling to help people in their own home countries, in their own regions. We have also a center or a clinic in Afghanistan. You see on the right side my colleague in Kabul. You can see a bit of the Kabul city from the window in the background. And in the upper photos, you see the outreach work we do in 16 provinces in Afghanistan, the face-to-face counseling. And on the left side, our counselors in Hamburg and Erfurt from Eritrea and Syria. For example, our Syrian counselors are bringing the service or help to the organizations based in Jordan and Lebanon in refugee camps. So.
Thank you.
Well, what I want to also to mention is, well, our vision is to bring this approach or services for all the people who need it, also in Europe. So if you are interested in this service as a component, so we can talk.
Thank you. And Maryam, how do you work together with more regular or mainstream mental health services? I mean, how do you further attempt to make them more cultural sensitive, or how do they look at your services and what you provide and your important work that you are doing?
Yeah, at the beginning they were, of course, skeptical. The healthcare professionals were skeptical. But then after they could see, we worked in Berlin in 2016 in almost 37 refugee camps. And they could see the improvement of the symptoms, that the clients got better relatively quickly. And then they did an evaluation inside the helping systems and the refugee shelters, and then they could see, for example, that there is less need to call the ambulance, there is less call to police stations, less conflicts among the people, and the people were also ready to accept all services that are offered to them, so they could see the sense. But now I think we are quite good acknowledged, and we are acknowledged among the refugees themselves, because we speak their native language.
Yes, and it's very important, the approach that you take to build on the resources and the skills of refugees themselves. So what further action is now needed, also for you, Lou, after describing the quite dark situation in the UK, and I do not even want to think of the prognosis of this situation. So what sort of policies are needed from your perspective to take away the barriers? So what kind of actions do you need in both? So maybe first Lou and then Maryam. Yeah.
I think we sort of have to look local at the moment, and certainly what Doctors of the World have been doing in the UK is we've rolled out a Safe Surgeries initiative. And so the NHS England guidance is on our side, it's just not implemented, as I mentioned, with people often being refused primary care. And I would say this because I'm a GP, but without primary care, I think it's very difficult to get the other access to healthcare people need. So our Safe Surgeries initiative, we've signed up over 200 GP practices so far in England. And what it is they have posters up in a variety of languages saying, everybody welcome, you don't need ID, you don't need a visa or passport or anything to register here. We won't share your data, you're safe, you're welcome. And to encourage registration, so to reduce those barriers, as well as trying to do outreach rather than getting people to come to the GP surgery, recognizing that's not always possible for people. So I think that's one very concrete example of a way that we can try and improve access to healthcare ourselves rather than waiting for a bigger policy change or rhetoric change.
Maryam?
Yeah, well, all facts have been told before. Also, related to Germany, we need to think a bit out of the box and create inclusive preventive projects, not only limited funded projects. And then what we do also, we get into contact with our clients on eye level. We don't pathologize them, and this also empowers them. It has a big effect on them. So that many cases, like I said, the symptoms like depression, anxiety, PTSD, could be also treated in a more low threshold way, a more preventive way. And then what we did, actually, we created a filter which was helpful for the healthcare system too. And it would be nice if this concept could be established on the long term.
Thank you to both of you. So let's now move from UK and Germany to France. And I'm delighted to introduce to you Jean-Paul Moatti. He's the director of the French Research Institute for Sustainable Development, and he's actually based in Marseille too. So Jean-Paul, perhaps you can reflect a little bit on what has been said here, also on the wider health inequalities, and maybe linking it further to the global level and to the Sustainable Development Goals, where you have been active very much. So Jean-Paul.
Yes, thank you, Carol. I've been a professor of health economics here in Marseille for a long time, and since the last 5 years I've been the director of the French Sustainable Development Institute, whose mandate is more than health, and so we have to deal with a lot of issues. So I'm very happy to be able to see some old friends here, but it gave me the opportunity to be one of the 15 scientists who were mandated by the Secretary General of the UN to draft the first critical assessment of the Sustainable Development Goals implementation that was published recently. It's GSDR 2019, if you want to find it on the web. And I think that you have the cover of a report in the next slide, Carol. I would like to maybe give to you a few of the key messages of a report that may be of relevance for the current discussion. The first message is a message of urgency. Clearly, very few of the 169 targets of the 17 goals are on track. Maybe child mortality, although we have a problem terrible in sub-Saharan Africa, but most targets are off track. That's the case for maternal mortality, that's the case for NCDs, that's the case for universal health coverage, and I could give you examples in the other fields. But the new message from the report is that we're not only off track, on major issues we are back track, we are regressing. We are going in the good direction, in the wrong direction. And that's for two reasons. Either because we have not been able to reverse the deterioration of a situation that was prevailing before the SDGs. That's the case for the loss of biodiversity. IRD researchers just published this week a paper showing that one third of all African tropical plants are threatened by short-term extinction. That's the case also for ecological footprint of our modes of production of consumption. Or we are regressing because as soon as we have recovered from the big economic crisis of 2008, because our current model of growth and development is totally inappropriate, we go back, as soon as growth comes back, we comes back going in the wrong direction. That's the case for climate change and greenhouse gas emissions, which has started to go up again, plus 2% last year. So the major goal of having zero net emission of these gases, which increase the world's temperature in 2015, is going more and more far away from us. And this is the case of inequalities. We have an unprecedented rise of inequalities at world level in the history of mankind. Today, I hope not many of you of this kind are in the room today, 1% richest part of the world population control more than 1/3 of total wealth, while the poorest 25% only benefit by less than 10%. So that's the second message of a report based on the scientific literature in the field of health, but more generally, of course, is that the SDGs should be the opportunity of a change of paradigm. With the Millennium Development Goals, the idea was to focus on extreme poverty as defined by the World Bank as income monetary poverty, the people living with less than $1.9 per person per day. And if you define poverty this way, like the World Bank did for a long time, or like Esther Duflo did recently, you can claim victory, because we had 1 billion people going above this level between 2000 and 2015. But it's a fake for many reasons. I mean, it's a problem. Of course, it's important, it's good, but it doesn't solve the problem at all. Because in the same period, we had 1 billion people going between $2 and $3, totally vulnerable to any type of ecological, economic, political, military shock. The second reason is that, of course, now we all agree, and I'm sure it's the case in this room, that we have to define poverty not only by an absolute monetary threshold of extreme poverty, which, by the way, is for 85, the extreme poor today in the world are 85% concentrated in fragile states, like in the Middle East, in Southeast Asia, and in Africa, or in conflict situation states. But of course, especially in Europe, you have to define poverty as multidimensional approach. And if you calculate like this, of course, for example, in the 105 countries for which we have data, the multidimensional poverty index shows you that about 1.5 billion households are confronted to overlapping deprivations, including health and education, among other things. And of course, one of the most vulnerable groups to multidimensional poverty is the displaced people. Last year, we had more than 70 million displaced people in the world, the highest figure ever in statistics, at least, and about 30 million of them are refugees, people who have to live who are not only displaced in their own country and region, but from one country to the other. And so one of the important messages of our report, which of course doesn't invent everything, but synthesize things that are now agreed even by former leftists like me, but even by people from the World Bank, from OECD, and even from people from the IMF, is that reducing inter-country but also intra-country inequalities is absolutely key for poverty eradication, for the whole 2030 agenda. And the important thing is that it is not only a matter of social justice. Because if you say it's only a matter of social justice, to some extent, the British government or the US government that tried to oppose the inclusion of inequality in the 2030 agenda are partly legitimate, because they say, well, it's a problem of national sovereignty. We may have different preferences about the degree, and it's a matter of social debate and political debate in the US, in France, in the UK, to what extent we want to transfer wealth from the rich to the poor, from the disadvantaged, the disabled, and so on. So But in the report, we take the consensus for all economic literature today in the world, saying it's not only a matter of social justice, it's also a matter of economic efficiency. If you are not able, if we maintain such incredible level of inequality, we may never have a sustainable growth compatible with sustainable development and with the respect of planetary boundaries. And so, if I have still a few minutes, I can tell you about the third message, which is, I think, relevant for the migration debate. The third message is that the arrows, the relationship between SDGs, are more important than the SDGs individually. And on this, I have to convey a message to you, since I see the public health a little bit from the outside. There is a paradox. Us people in public health, usually we say, if we want to improve the health of the population, it's not only a matter of medical care. Of course, it's important, but it's also a matter of being able to concentrate and to interact with all the policies in the environmental field, in the sanitation field, in the social protection field, in order to reduce inequality, have better access, and so on, right? But paradoxically, what I see from my UN point of view now is that in the field of health in the last years, we have not been the best in making the relationship between the targets, even in SDG 3. 14 billion for the next 3 years for the Global Fund to fight AIDS, TB, and malaria. That's great. I totally support that. But to what extent we will be able to mobilize this money to really change the health systems in the countries, I'm a little more skeptical about this. And even more, we are not at the forefront of the ones trying to make the relationship between SDG 3 and all the other the other SDGs, taking into account the potential negative externalities and trying to maximize the positive synergies that us in public health know about that. And to have, just to conclude about migration on this, I totally agree with Neil Adger and others' recent paper in Lancet Public Health, saying that the 2030 agenda has treated, at least implicitly, the migration problem as an unplanned and temporary phenomenon, as a problem that has to be solved. But in fact, if you take the GSDR approach, that the focus should be on the interactions, on the synergy between the goals, you see migration not only as a problem, of course we have to take care and to fight against discrimination, but also as a part of a solution, as a way to improve sustainable growth, as a way to create new pathways about that. That doesn't mean that we should accept, unregulated flows, that you should accept the way some non-democratic states play with their population, of course. But we have to change the focus, and I hope that the next conference may look about that. Thank you.
Thanks a lot, Paul, for highlighting the need to shift the paradigm and the need for intersectoral action. And as the title of your report, The Future is Now, that is a very strong statement, I think. And I think you have all been very strong with your statements and to think out of the box and some fresh and new insights in how we can tackle these complex realities. We said at the start, when we were preparing for this plenary, that we wanted a solution-oriented approach also. And I think you came up with many different solutions, which I just want to summarize here. It's about, obviously, universal accessibility. It is the outreach, which is important. It's making services more culture sensitive. It's building on the existing skills and resources of migrant communities, tackling discrimination, telling the stories, the new paradigm, and in particular also using the SDGs for transformation. And the SDGs is not something only for the UN or for the EU or WHO or the countries, but that's a bit of an elitist approach. I mean, the SDGs is for all of us. People in the cities, but for all of us on the ground, and to make them and to relate to them and to improve further all of our work. So I would like to thank all of you for your fantastic contributions, and I would like to thank the audience for listening and being here with us today.